Good morning, good afternoon, good evening, everyone. My name is Mohammed Zaman, and I wanted to welcome you all to this webinar today. I am a professor of biomedical engineering and global health at Boston University, and I want to welcome everybody I know who's joining from different parts of the world. My own research focuses on antimicrobial resistance, particularly in communities that are displaced because of conflict, because of climate change, and xenophobia. In the current moment today, we see this happening in many parts of the world, not just in Middle East, but in Ukraine, in parts of sub-Saharan Africa, Sudan, and many other parts of the world that may not be on our news radar. I direct a Center on Forced Displacement, the aim of which is to bring together scholars, students, staff, practitioners, and communities from all over the world to think deeply about the question of forced displacement. That is, people who are forced to flee their homes because of conflict, climate change, and xenophobia, as well as persecution. At the same time, there are communities that are unable to leave, the issue of immobility, because they want to leave and the system doesn't allow them to do that. Oftentimes, we also don't think of people who are stateless, communities that are not recognized as citizens of any country, of any nation state. These are people all over the world, sometimes even in our midst. The Center on Forced Displacement aims to develop new knowledge, thinking about the historical, cultural, economic, political, and technological dimensions of forced displacement, and also brings together ideas on how to address these issues with communities, alongside communities, in ways that are both evidence-based and contextual in terms of the solutions that we provide. I encourage all of you to engage with us. We have not just newsletters, but also multi-genre magazines, events, and we're very, very interested in thinking about cross-cutting issues. For example, the interface of health and access to medicines, antimicrobial resistance, population dynamics, people who are forced to live in these kinds of communities, and how it affects us all, whether or not we engage with forcibly displaced communities or not. Today's event, in many ways, touches on several of these issues. It is part of World Antimicrobial Awareness Week. It is very relevant to the issue of communities that are often displaced and are not sort of on our radar. It is also brings the dimensions of people who work in these communities and the work that they do alongside international agencies and alongside researchers, scholars, and practitioners. So I'm just absolutely delighted and honored that I have the opportunity to be moderating today's session. The format is going to be that we will have small presentations from our wonderful colleagues, and I'll introduce them in just a second, and then Q&A will be towards the end of the seminar. I also encourage colleagues, if they can introduce themselves using the chat button. I know some people are already doing that, and we are very excited to see that. We also hope that this is an event that allows us to foster new collaborations, allow us to engage and learn with each other. Despite the fact that we are not in person in one room, I hope that we are able to sort of build a community and learn from each other. I've had several of these. I know that there are many more questions that are asked than the time that is available. So we hope that people will continue to sort of use the chat function, provide resources, connect as needed. So let me first introduce you to our three wonderful colleagues who are here. First is, of course, Dr. Angela Cateriano, who is a health policy advisor at MSF. Dr. Cateriano is a medical doctor with experience in different contexts and areas of global health, and particularly on infection control. She's an experienced project manager and a consultant and has been working with MSF since 2009. Angela also holds a master's degree in infectious disease control and MBA in healthcare administration and master's in international relations. Dr. Noor Shamas is a member of the WHO Task Force on Antimicrobial Resistant Survivors, she's a Lebanese infectious disease and antimicrobial stewardship clinical pharmacist with an MSc in global health policy. She recently consulted with the WHO on scaling up hospital antimicrobial stewardship and developing AMS centers for excellence in the Eastern Mediterranean region. She's also a member of the WHO Task Force of AMR Survivors, as a carer for her mother who has survived antimicrobial resistance infection. And Suzanne Narrow is policy advisor at AMR Policy Accelerator, a group that I've had the pleasure of working and learning from. Suzanne is a policy advisor at the Global Strategy Lab, where she leads policy research projects to support governments and public health organizations to design policies on antimicrobial resistance. Her more recent policy research includes how national action plans on antimicrobial resistance can be more gender inclusive and the barriers migrant and refugee communities face in accessing antimicrobials. As you can imagine, these three colleagues bring a wealth of experience, diversity of practice, and also, as you can see, from different regions of the world. The challenge of antimicrobial resistance, unfortunately, is global. It is also one that touches lives across many political, social, and economic spectra. So this is something that I'm very excited to hear, and I'll pass it to Suzanne to take it from here.
Awesome. Thank you so much, Mohammed, for that warm introduction. I'm just going to share my presentation. Just can I get a quick thumbs up that everyone can see it? Yes, perfect. Okay, so thank you so much, Mohammed, for that warm introduction. I am so thrilled to be here alongside Noor and Angela. I'm really excited for this panel, and I am also very excited to be kicking off this webinar on the gender barriers to antimicrobials among migrant and refugee populations, which is perfectly aligned with this year's World AMR Awareness Week theme, which is to educate, advocate, and act now, as it is critical that we create bold commitments and concrete actions towards addressing the needs of migrants and refugees, specifically those that identify as women and girls. So, what's the link between equity and AMR? So the definition of equity, this is taken from WHO, is the absence of unjust differences which are avoidable or remediable among groups of people, whether those groups are defined socially, economically, demographically, geographically, or by individual characteristics such as sex, gender, migration status, ethnicity, disability, or sexual orientation. So it's really important that we consider equity when tackling AMR, because the drivers of AMR are unfortunately the consequences of inequities, such as lack of access to or misuse of antimicrobials, lack of clean water, sanitation and hygiene, poor infection prevention and control, poor access to quality healthcare, and also lack of knowledge. So today, we're going to be focusing on gender and migration status as the two factors of equity. And the reason why we're focusing on this is because we've done some really amazing work in collaboration with WHO over the past 2 years. And this is also a personal interest and expertise of my own. And just before we begin, what do we mean by gender? So this is the socially constructed attributes of women, men, girls, boys, and gender diverse populations. So what's the impact of gender inequalities on AMR outcomes? So as I just mentioned, in collaboration with WHO, we conducted an evidence review. And overall, what we found was that women, men, girls, boys, and gender diverse populations all experience different health outcomes related to drug-resistant infections from prevention to treatment. And we found that all of these barriers are very context-specific. And obviously today we're going to be focusing on women and girls, but I highly recommend you to check out our full guidance document, which will also be put in the chat. So for prevention, we found that poor wash infrastructure within communities and at healthcare levels, healthcare facilities, can have a disproportionate impact on women and girls' exposure to drug-resistant infections. So what do I mean by that? Within communities, we can see that women often take on household responsibilities such as water fetching, caretaking, food preparation, and handling. And in combination with poor wash infrastructure, this can really increase their exposure to drug-resistant infections such as E. coli, which is increasingly becoming drug-resistant. But also at the healthcare facility level, So women have more are more frequently exposed to healthcare facilities, and in combination with poor sanitation and clean water, this can also increase their exposure to drug-resistant infections. And also, we can see that women take up the majority of nursing roles in IPC workers, and unfortunately, personal protective equipment (PPE) is typically designed to fit the standard male body. Therefore, they're also not protected effectively. We can also see that stigma can influence women and girls' access to healthcare services. So stigma associated with urinary tract infections, sexually transmitted infections, and also TB can prevent women and girls from accessing the formal healthcare sector. Household responsibilities and financial constraints can also impact women's access to healthcare. This is because of time and financial constraints. So this can also force women and girls to seek care from the informal sector, which puts them at risk for substandard or falsified medicines. We can also see that gender norms can impede women's access to diagnostic services. Gender norms such as the need to be accompanied by someone, treated by a female physician, or the fear of providing bodily fluids as it can be seen as unfeminine. We can also see that antimicrobial prescriptions are influenced by patients' gender. So we've seen a lot of studies where women are prescribed more antimicrobials than men. But we can also see that women are more likely to purchase over-the-counter antimicrobials because of norms, limited financial resources, or power to access household funds. And together, this can really contribute to self-medication practices, the saving and or sharing of antimicrobials as well. So what about the impact of migration status on AMR outcomes? So again, in collaboration with WHO, we conducted another evidence review, and we found that migrants and refugees experience barriers from both the health system side and the patient side. So some barriers from the health system side include limited resources and capacity of healthcare facilities, long wait times, high costs for services, lack of translated materials or interpretation services, and also inappropriate antibiotic prescriptions for migrants and refugees. There's also patient-side barriers that migrants and refugees can encounter. This can include financial restraints. So this can be from the direct expenses related to receiving a healthcare service, but also indirect financial needs. So transportation to and from the healthcare facility, but also a fear of loss of income, especially for those that are daily laborers. Stigma around certain infections can also deter migrants and refugees from accessing healthcare services. Again, stigma around STIs, TB, and UTIs. There's also a fear of deportation for undocumented migrants, and also limited education on AMR. And then this can really cause self-medication practices, lack of adherence to, or incorrect use of antibiotic treatments. So this manuscript is currently under review, but I highly recommend that you sign up for our newsletter and you will be notified once it's published. Okay, so in my two last slides, we just saw that gender and migration status can create poor AMR health outcomes. What happens when these factors intersect? So currently, women and girls represent approximately 135 million migrants and 21 million refugees. For context, that's the size of Germany plus the UK. So we have limited research on this, but we have seen some studies that show an increase in prevalence of drug-resistant infections among migrant and refugee women, especially drug-resistant MRSA and drug-resistant Enterobacteria CI. So women can have increased vulnerability and exposure to drug-resistant infections, for example, through lack of clean water and sanitation in the community and healthcare facilities, which can really put them at risk for increased risks for DRIs. So I mentioned that in my previous slide. So this is because of menstrual hygiene needs, increased contact with the healthcare system through childbirth and through pregnancy and childbirth, but also through household responsibilities. So water fetching, childcare taking, food preparation and handling. And also, there's also migrant and refugee women also can experience an increased rate of sexual violence, and this can unfortunately increase their risk also of drug-resistant STIs, specifically gonorrhea. Women are also typically the household health caretakers, and therefore migrant and refugee women may encounter barriers to accessing quality health care because of limited resources for services. So this can include long wait times, high costs, and also the fear of deportation. So after all of this, what are opportunities to educate, advocate, and act now to address the needs of migrant and refugee women and girls? First, we need more research. We really need to promote research to strengthen the evidence base on the intersection between gender, migration status, and AMR. But we also need to incorporate policies and actions that promote equity into national action plans on AMR. And what can we do now? So we can also start to develop and incorporate gender-sensitive and cultural competency training for healthcare workers to strengthen the care of migrant and refugee populations. And we can also start to conduct community-based initiatives to strengthen the education of AMR among migrants and refugees to promote appropriate treatment practices. Thank you so much for listening. I will hand it back over to Mohammed.
Thank you so much, Suzanne. This was wonderful. I have lots and lots of questions and thoughts, but I want to sort of talk about two general themes and then have our colleagues, Dr. Catriano and Dr. Shamas, sort of take it from there. We know, unfortunately, that conflict continues to increase and has a disproportionate impact as a result of that on injuries, infections. How does one think about those kinds of things? Partly because this challenge is, you can imagine in a place like Ukraine or Gaza or elsewhere, there is an issue of supply chains. To be able to do good testing and to be able to say, okay, we want to do antimicrobial susceptibility test is often not possible. And that in many ways reinforces some of these challenges. So that's one thing. How do we think about sort of in this world of conflict and humanitarian crises? So that's one aspect that I think is something we should think about. And I think the second thing is, and I'll touch upon this later on as well, is the fact is that there's a policy arm that often is very rigorous, but by the time it gets to the local communities, it loses the momentum, it loses the funding, it loses its ability to be enacted. How should we think about this disconnect between good evidence-based policy and action on the ground, for which there are many factors? I want to sort of give it to Dr. Catriano and then Dr. Shamas to sort of respond and sort of think about that. And then we'll go to Noor for some thoughts on this as well. But please go ahead, Angela.
Thank you, Dr. Samam. And I just wanted to start thanking for the invitation, and thanks, Suzanne, that was great. And I think many of the things you mentioned, we see them in the field, right? Speaking from the health sector, AMR is an issue of access to quality care. And people excluded from quality care are more susceptible, they are made vulnerable. So just let me start by saying that in the case of migrants, displaced, and refugees, these are not humans that are born more vulnerable to AMR, are in many cases the detrimental policies that make them more at risk and more vulnerable to AMR. So that said, the exclusion from the health system, the detention, the contention measures, people are forced to live in overcrowded settings in deplorable living conditions. They have limited access to water, sanitation, as it was mentioned. But added to all these, they are not given or provided the access to quality care they need in their path. And in many of these restrictive policies, create the fear on them that if they go to the health center, if there is an administrative barrier, they don't have documents, they might be then criminalized, they will be sent to a detention center, deported, etc. So all these barriers can be solved by policies. I think, like, for instance, let's take Bangladesh. In Cox's Bazar, we have around 1 million Rohingya refugees that are contained in overcrowded and insecure refugee camps with limited access to care. So I think in these kind of places, MSF witnesses how patients often interrupt their antibiotic regimes. They ask for early discharge because they have the kids at home, and women usually opt for home deliveries in unclean environments. And all of this is due to the policies, to the contention and detention policies they have in place. So I think this is something we need to address to increase the quality of care. And as you mentioned, Dr. Saman, I think, yes, supply chain is one of the access barriers, but we're still far from understanding even what is happening in humanitarian settings and in these crises, because as Susan mentioned, evidence is still scarce. But this should not stop us from acting. I mean, the needs are there and the needs are clear. I will say what we need is documenting, more research, but also more people in the ground. We need more actors in the ground, humanitarian, medical actors. Not many are working on AMR. And AMR actors are not usually working in humanitarian settings. And just to be clear, many humanitarian settings are not included in AMR national action plans. And in many cases, states are the perpetrators of the exclusion. So we need to think about these complexities and to see how we integrate more of these voices and this expertise there, because what we need at the end of the day is context-adapted initiatives to address these access barriers. But yeah, I leave it there for now. Thank you.
Noor, thoughts?
Yeah, I have a lot of thoughts. It was very interesting as you were presenting, Susanna. I mean, a lot of the things that you've mentioned are factors or risks or exposures that my mom basically told me about through her experience rather than from me reading about it in a book or a report. And I was surprised because as a healthcare worker working in AMR, I had never thought about stigma on UTI. I mean, why would you stigmatize urinary tract infections? I'd never thought of it before. And that's like takes me to what you were just saying, Angela, just thinking about all the actors on the ground that need to be working on AMR. And of course, I mean, I'm here as a patient advocate, but also thinking about what the patients can bring to the discussion, because I think if we would have listened to people like my mother or other people much earlier on, I think we would have identified a lot of things that we could improve. And unfortunately, growing up in Beirut, I've always been exposed to the definition of inequity, whether with my Lebanese family and friends or Palestinian refugees just down the street of my very, very, comfortable neighborhood. And so I think that, yes, definitely there needs to be a lot more work in the field, but also like integrating quality of care, which you mentioned, into the whole processes, which is what is lacking. Like if we think about AMR, we need to think about quality of healthcare services, quality of just services, and how people access healthcare. And I'll talk a bit more about my mother's experience a bit later. But I'm very excited that more work is being done on this now.
Thank you so much. So in this next 15-minute period, I'll have some questions for the panel, and I hope that this will also catalyze questions from our attendees as well. So let me start with you, Angela. What barriers is MSF facing in humanitarian settings, and how are they overcoming these challenges? And if you could give specific examples for our audience, that would be very, very good as well. So what do you think?
So, just to say, I think humanitarian crises in general are unfortunately becoming more frequent. Not only malnutrition crisis, but natural disasters due to extreme weather events, conflict, and others. So, we have more needs. But at the same time, inequity is on the rise. Nationalism, to some extent, is on the rise. And the supply chain issues have been exposed by the pandemic, right? So things are not going well. Some of the access barriers we see And I'm gonna refer specifically to conflict-affected settings, because let's be honest, this is not an invisible issue; it's a neglected issue. These populations are at higher risk, and we know conflict is a driver to the development and spread of AMR. So the attacks on medical facilities, the brain drain of healthcare workers, the disrupted supply chains, as we mentioned, all of this contributes to and affects already vulnerable populations. So, for instance, in Kabul and in Khost, in Kunduz, in these places in Afghanistan, what we see today is very crowded facilities, tertiary, secondary facilities. We have seen in MSF an average of 150% of bed occupancy, and this, of course, does not allow to implement good IPC or to give the quality of care we would like to, but the needs are there. So, and that is only to give a picture on how is to work in places with high needs. So what you find in these places is also a complex relation between the excess of antibiotics and the access to essential antibiotics. There are fragmented health systems where people can access antibiotics in informal providers and in private providers that usually happen to be the only provider in some places. And this translates into a financial access barrier for patients, who have to pay out of pocket. But it happens also that many of these drugs, are not well regulated. We don't know very well about the procurement, where they come, the quality. So this exposes patients to more risks. As I mentioned before, security barriers. We see, for instance, in North Syria, our staff has reported that vancomycin sometimes is donated by institutions and distributed by some other organizations without proper guidance. So the lack of hands-on in the field and these blind donations also make the problem worse. And to all of that, I'm going to refer to a point I made previously, is the lack of information. We don't have idea about the burden, the patterns, and we don't have proper surveillance and diagnostics. And I know there is a challenge on implementing in these insecure settings, but we need to invest more on innovative tools and adapted and context-adapted tools, because even if we want, these things are going to continue happening, and we cannot just keep neglecting them, and we call it invisible pandemic. It's a neglected one. So just wanted to say we need to keep working more in these settings to see how we adapt and we improve the access to surveillance, to diagnostics, and then we're going to have an idea on what we're talking about. But in the meantime, more immediate things we can do is to improve the IPC, access to clean water. This is about equity, as Susan and Noor mentioned. This is about human rights. So this is not a choice. Thank you.
Thank you very much. Moving on to Dr. Shamas, as a member of the WHO Task Force of Antimicrobial Resistant Survivors, you have deep knowledge of the personal impact AMR has had in your family's life. Can you tell us a little bit more about your experiences accessing antimicrobials and how that has shaped your own understanding and your thought?
Yeah, sure. So basically in 2018, I had already been working as a leading stewardship programs for a number of years. And at one point, my mom, in parallel, had surgery, after which, a big back surgery, after which almost 7 weeks later, she developed symptoms of a urinary tract infection. And then through that process, I learned a lot of things, like I mentioned earlier, the stigma of having to seek care as a woman and discussing sexually transmitted diseases, comparing it to urinary tract infections, and the stigma related to contact isolation whenever you actually are doing everything right when it comes to IPC, how that transfers, how is that explained to patients and their family and their relatives, to questions that she asked me about women's health and why we have such horrible antibiotics for women in general, and and now she has recurrent UTI, and overlap that, of course, with the fact that we pay for her healthcare out of pocket. In addition to that, the fact that even if you could buy everything that you wanted, things weren't available because she was in Beirut in Lebanon. This is 2018, 2019, where we were having a huge financial crisis. So even if you wanted to buy the antibiotics, they're not available. So I had to actually bring antibiotics with me from abroad in my backpack, hoping that border control won't say anything. I have a prescription, of course, and my mom's medical report and her doctor, but and she became an expert in identifying her symptoms. And throughout this process, just keeps telling me, can you talk about the story? Can you tell other people how we experience this? And on top of all of that, recently with the aggression on Lebanon, now we have had to take her out of Beirut. And we're very lucky because she could fly. She didn't have to run barefoot in the streets. She could take her antibiotics with her. But at the same time, and it comes to access to care and how we think about migrants and refugees. My mom is basically a financially supported refugee because, yes, of course, she's not living in crowded quarters, but she doesn't have access to healthcare. We have to pay out of pocket in a foreign country, which will gladly take us, and I'm very grateful. But a lot of people, you said earlier about immobility, but a lot of people can't move out of conflict settings. And so I think from all of this process, I learned as a patients and healthcare provider that you really need to integrate, going back to like basics. The first thing you do as a healthcare worker is do no harm. And so like donating vancomycin without guidance, for example, is doing a lot of harm. So there's a huge responsibility on donors to consider the interplay between humanitarian support and also what the patient actually ends up receiving and how we harm patients rather than help. There's a lot more to say, but I'll stick to that for now.
Thank you so much. Suzanne, we, as you and others have done remarkable work in thinking about One Health approaches. When we think of migrants and refugees or communities in conflict or humanitarian crises, we focus on people as we should. But there is a tremendous impact on the environment, long-term impact due to conflict, destruction of infrastructure, hospitals that are bombed, buildings that collapse and stay in that state for long periods of time. So can you tell us a little bit more on the environmental dimension of AMR and displacement, something that unfortunately does not get the adequate attention it deserves?
Yeah, thank you so much. I love this question. I think I'm going to answer this question kind of in two parts. First, to kind of talk about the importance of the conflict and destruction of urban infrastructure in AMR, but also to kind of think about the environment a little bit broader and how that can also impact AMR, kind of more forward thinking. And so, as you kind of mentioned, AMR does require a One Health approach. However, the environmental sector is often forgotten, both in decision making and also policy making. Part of the reason is because there's a lot of limited research on the role that the environment plays on AMR. But, we do know that antibiotic residues, resistant pathogens, and untreated waste and wastewater can enter the environment and create hotspots for resistance. And I think as Noor, Angela, and you, we've all kind of mentioned that conflict and the destruction of urban infrastructure leads to poor sanitation and limited access to clean water. And as I mentioned earlier in this webinar, during the presentation, that these factors contribute to the spread of infections, waterborne infections, which can become drug resistant, and unfortunately disproportionately increase women and girls' exposure to drug resistant infections. And so, obviously, as a policy advisor, I'm always trying to think of policy solutions. And I think my fellow panelists have kind of mentioned this, that, we really need to strengthen WASH infrastructure in displaced communities. We need environmental surveillance to detect resistant pathogens in water, soil, and in waste in and around displacement settings. And we also need to strengthen waste management systems. But the next thing I'd also like to point out is the role that climate change is going to have in exacerbating AMR and increasing exposure to vulnerable populations. Because when I think about environment, unfortunately, the first thing I always think about is climate change. And, climate change is going to force more people to migrate to flee extreme weather events such as floods, droughts, and storms. And so, unfortunately, we're also going to be seeing many more environmental or climate refugees. And as we have been discussing, migrants and refugees can experience health system and patient-side barriers. But also climate change through the increase in temperature is also going to be creating ideal conditions for the proliferation of infections and because of increased rates of bacterial growth. And even some studies actually have shown that the increase in temperature has increased the incidence of AMR in both community and hospital-acquired pathogens. So I think it's really important that we take these environmental considerations more seriously when we're when we're developing national action plans and really creating policies. Thank you. Over to you.
Thank you. We'll take one more. I'll add one more question, and then we'll ask our audience colleagues. So question going back to you, Noor. The fourth Global High-Level Ministerial Conference on AMR just took place in Jeddah, focusing on implementing the recently adopted political declaration on AMR that happened a couple of months ago. What did you learn there, and what do you think is needed? And as I mentioned in the beginning, in the past, higher level conferences have said all the right things and have sort of talked about this. But by the time it comes down to country level, the momentum is lost, the energy is lost, the funding isn't there. So what are your hopes and concerns from this most recent meeting in Jeddah?
Thank you. Yeah, it was really amazing to be part of that meeting, of course, and it was nice to see everybody talking about the next steps. And of course, everybody talks about the importance of accountability and action and looking at actually how, where the money is going to come from, who's going to do the work. And my work is generally about implementation. So I love that perspective. But I think very often the countries that need to be there aren't able to be there. Like Lebanon wasn't there because there's no way that people from the Ministry of Health of Lebanon is going to drop everything and come to that meeting, which is super important to them. And I know that for a fact with discussions, but there are at the moment resources and priorities that need to be put in place. And so that's why I really think one thing that was highlighted at the meeting that was very nice is the important role of civil society in talking about AMR and bringing the discussion in. If we talk about national action plans, those are for nations that have national action plans. And for those that don't, sometimes civil society can elevate the bar in discussion, whether it's in local communities to how they can improve access to water and wash in that small community, or whether it's discussing the importance of not using over-the-counter antibiotics, or even putting your governments accountable to you as a citizen, and that's, I think, what was nice to see at the meeting. And I really hope to see a lot more support for civil society through funding, but also research on communication and how we can talk about AMR in vulnerable populations specifically. That's a big part of what I look forward to seeing.
Thank you so much.
Sorry, I think we have a little bit of time. So, Mohammed, I would love to ask you a quick question. So, as you know, obviously at the AMR Policy Accelerator, we're really into bridging research into policy. And so I'd love to pose a question about how can we mobilize research on AMR and migrant and refugee communities into policy action?
Yeah, thank you, Suzanne. So I direct a center that is a research center. So we are not an aid agency. We are not a group of people who is working at the front lines. We work with them. So to to mobilize the policy part, I think we would say that there should be three things. First, there's this sort of, I think, a global message that nothing about us without us, right? So you have to include, engage the local communities, that people who work on the ground, to understand their challenges and context. So that's the first part that I think is absolutely important. The second part, I think there is contextual reality. So things in Rohingya camps are different from Gaza, from the US southern border. All of those need to be incorporated, and they're things that are common. And one needs to separate both of those and look at both of those simultaneously as well. The contextual realities as well as the global realities, and generate evidence based on that. And I think there is a tremendous value in storytelling. There's a tremendous value in bringing lived experience. So data is good and value has there, but people are often moved by individual instances and stories. And too often, I feel policy centers tend to focus on the data and sort of the evidence without bringing the human context in there. So for longevity of these things, you have to sort of contextualize it with people. And I'm glad that today people spoke both as caregivers and as family members, but also as researchers. I think that is absolutely critical if you want to have sustainable policy on something that is so critical and so urgent at the current moment. So with that, we have time, about 12 or 13 minutes for people to ask questions. We have one from Kayla. Please, other colleagues also join. And that question goes to Angela. I was wondering if you could expand on the call for surveillance data in migrant and refugee populations. What would be the best practice and best place for this? Who should do it? Patients or pharmacists? I appreciate many of the people involved are overstretched, and that's a very, I think, accurate observation given the often overcapacity settings. How do you think? Where do we move on that front? Thank you.
Thanks a lot, and thanks for the question. I think it gives me the opportunity to explain a bit something about that, because I think there are some dangerous things about how we take data coming from migration. And I just want to say, I think we need more data definitely about humanitarian settings, how to innovate, how to include. But in the case of migrants specifically, we know that the policies are harmful. We know that, again, many of the restrictions they have to move, many of the restrictions they have to access free quality care, those are the ones harming people. But we need to be also very sensitive towards the narratives used under the global health security that sometimes portray people as vectors of disease. I've seen a couple of studies on migrant population where they take samples of colonized skin, and I wonder, these are not patients. Why are we taking samples like that? And there is a strong narrative then saying, oh, people are bringing disease. So I think we need to move away. In the case of migrants, this is why I separate this particularly, because many of the barriers they have are politically easily to address if there is the willingness, right? And I think in that case, we will keep advocating for a world without borders, for a world where everyone should have the same right to access quality care. There are more, I think, implementation things to show than epidemiological things to show. We can raise more evidence, we can bring more evidence about how harmful policies or how the situations expose or increase vulnerability in these people. And I think that is what we need today to change the policies. I think epidemiological, surveillance studies might bring the risk of increasing this securitization of borders and having a detrimental effect on people's health. But I would like to hear others' views also.
Great. Anybody else wants to comment? We have two more questions which I'll take, but if anybody also wants to comment on this first question on data and surveillance and how to do that, and I want to add one thing. This issue of doing it ethically is critical, right? So we work in migrant shelters in different parts of the world, And there are important considerations that need to be looked at in terms of, are you doing it for the right reasons? Are you putting somebody's life at risk? Are you just doing it for your own publication? Or there is real value there? And I think I'm a strong proponent that we need to involve ethicists and historians and ethnographers, in addition to the local community and researchers. So public health teams need to think deeply about the impact, positive and negative, about their work and whether it can harm people, the very people that you hope to help. Noor, what do you think?
Yeah, first, I completely agree about increasing social sciences research in the field. I think where it's really time for that. And of course, it's really important to do more surveillance. And maybe I just wanted to share an example that probably, Angela, you're more familiar with than I am, but I recently saw the poster when I was at a conference in Istanbul. And it was MSF's team that shared an amazing work on osteomyelitis in Gaza, and basically looking at what type of organisms patients had and their outcomes. And one of the things that struck me as most sad, of course, but important to think about through this surveillance research piece is that a lot of patients would reject amputations because they had osteomyelitis, basically to direct hits to their kneecaps, basically, very often. And they would do that because, can you imagine being a refugee with an amputated limb, how you would then, in a continuous contracted conflict? So I think that, yes, of course, it was very interesting for me as a clinical pharmacist to look at the organisms, but also that specific piece identified the barrier to optimal care for patients with osteomyelitis that led them to not agree to an amputation, which reduce their likelihood of successful treatment. So I just wanted to highlight that example that I thought is an excellent example of how you could do surveillance in these settings. And yeah.
Great. There are three questions, and I'll combine all three of them and ask all three of our colleagues to reflect on this. Arnie asks, I particularly agree with the comment on the need to prioritize access and acknowledge policy failure as a reason for lack of access. What kind of policies do we need to put in place to address this injustice? So that's one question. And policy has been a theme that has come up in other areas as well. So Bethany asks, what percent of, I'll come to that in a second, but let me first take Arinda's question. How do you propose AMR surveillance in terms of new policies implementation? So one asks about what kind of policies do we need? And the other one asks about policy implementation. Bethany's question is a different one, and one I think that is important, is that there are lots of donated antibiotics in these settings. And how do we sort of balance this issue of the fact that there is excess and lack of access? And the quality of donated antibiotics is uncertain. And that in some ways reinforces the problem. So let's take first two questions, Arnie and Arinda, and 6 or 7 minutes. Anybody? So Angela, Suzanne, or Noor, on what policies do we need and how do we make sure that implementation? Go ahead. Let's start with you, Suzanne.
Okay, I can kick it off. I think I'm going to talk about kind of what policies we need, but I'd really love to hear from Noor and Angela about the actual implementation of it. So obviously, we need universal health coverage. I mean, this is something that I think we've been advocating for so long in this space. We know that in low resource settings, there is limited access to antimicrobials, and this is really fueling vulnerable populations such as women and girls to seek antimicrobials from the informal healthcare sector in self-medicating, and this can really fuel drug-resistant infections. But also, especially when we're speaking about migrants and refugees, those that are undocumented, this is a really big problem for them to be afraid of actually accessing the formal healthcare sector. And so through this, I think we really need to have policies that allow for safe and legal access, despite one's status as being an undocumented migrant and refugee. And with that, I'll pass it over to my panelists.
Noor and then Angela.
So I think that if you categorize the different settings contextually a little bit, like the urgent humanitarian settings or contracted conflict versus situations where actually access and excess are a problem, but not necessarily just the lack of availability. I think you can come up with different approaches. So, like you said, Suzanne, universal healthcare coverage, but what responsibility do we put on care providers in terms of providing safe care? I think that MSF does a really good job, Médecins du Monde, and this is not to name people here that are here or not here, but maybe others are doing a lot of work, but maybe they don't share it with us. But bringing to the table focus on the policies that are stewardship sensitive is going to be very important, and asking people to share. That's, I think, number one. But also in terms of implementation, like you already said, is trying to find ways to get information from the field. And in order to do that, you need a bit more funding, because everything is focused on just providing the services without making streamlined processes to get data. And I think maybe we need some help from maybe people that work in marketing and legal institutions to help us frame the approach slightly differently than we do. Because right now it's about human rights, but whatever is happening now and everywhere in the world is not considering human rights all the time. So maybe trying to find ways to frame it from a cost-saving perspective, and how, we're all connected from one health perspective. And I think we know that already, but I think it's time to discuss it for us even in the front line a bit differently. And
Angela.
Thank you. I don't know, like, this is so broad. We can start anywhere. Like, which policies do we need? I think we have some policies. It's how we are implementing the policies. If you take a look, like UHC and primary care are fantastic entry points for leveraging AMR, right? But how are those implemented? And I can tell you already, in emergency places, there is not clarity or no one to execute even. And we're talking only about financial coverage, when in many places what we lack is actually the effective access. You might have as a right universal health coverage as financial right, but you go to a facility with empty shelves. You go to a facility without a doctor. You go to a facility and it's closed when you can come. So I think all of these things play a role, but they are on paper. So I think we need to start taking serious the commitments we make, either in a UN high-level meeting, in a ministerial, and we need to start pushing for translating this into action. And that is something that we've been missing. Like, we celebrate, if you take a look, it's been almost 10 years since we had the first declaration. How much has it changed? How much things have changed in terms of AMR? And I think now we have the opportunity to really translate this into action. Just a few things in terms of migration. I think, again, I'll go back to some detrimental policies that make people more vulnerable. But then also, if we look at the money, and thanks, Noor, for mentioning that, because without money, things will not happen. So yes, there is a lot that has to do with the fragmented and the silos that we have today in global health. Everyone is looking at its own area, as its own funding, and we need to streamline, because AMR, again, is very transversal to all the access to care. So you cannot come just to have the global fund here and USAID here, and domestic resources just go into another area, and to not connect the dots. Because from vaccination to facilities to people's education, everything is connected. So we need to find a way to streamline and to identify, okay, then, this is contributing to AMR. Where are the main gaps? I tend to think, I don't have evidence. I tend to think that microbiology, surveillance, and funding civil society are things that will come as underfunded. I don't know. But someone needs to do that work, to identify where are still the remaining funding gaps. And then I think there is still a strong call for international solidarity, because these countries and these communities find themselves pushed to go through a loan in a context where debt relief is discussed, exactly because a lot of their income goes to pay external debt. So we need to keep into account, okay, if we really want to take antimicrobial resistance seriously as a global priority, we need to think about how relieving these places from debt, or at least not to merge them in another debt. And we need to execute more global solidarity. So yeah.
Thank you so much, Angela. I'm going to take Bethany's question because I think that's an important one about this issue of drugs and their quality and their sources. I think I'm going to pick up on what Angela said at the end is we need global solidarity. What that means is that you need to institute the same kind of mechanisms of care that we would have for anybody, which means that if we are uncomfortable with unknown source antibiotics in our midst, that should also be unacceptable for refugees and migrants. It is not to say that we shouldn't sort of do or contribute. It is that we need to have the same kinds of checks and balances for ensuring the quality of medicines, ensuring the quality of care that we have for everyone. That is a hard ask. I recognize that because of the political realities and the finances. But I think that is the only place to start. It is not just about AMR. The quality of medicines, whether they are for diabetes or whether they are for cardiovascular ailments, needs to have the same kind of quality control that we would expect for ourselves, for our kids, and all of that. How do you combat that problem? You combat that problem through two ways in my mind. One is sort of better surveillance and mechanisms, strengthening supply chains, things of that nature. But there is a philosophical part here as well, which is about sort of ensuring that everybody gets the same care that they're entitled to. Universal health coverage or universal health care is a meaningless concept if it doesn't include quality, right? It is not about access to care. It is about access to quality care. Otherwise, you're sort of creating distortions in a system between haves and have-nots. And as we know, migrants and refugees already are at the bottom of that socioeconomic ladder, at the bottom of our care and concern, and this only reinforces that. I'm really grateful for everybody who was today and colleagues at AMR Policy Accelerator, Global Strategy Lab for making this possible. It is both incredible that they thought of this and also timely. And I hope that this is the beginning of these conversations in large groups, in small in policy sectors, in community. I encourage engage. I hope that you will also do the same for Center on Force Displacement that I am privileged to lead. And really think deeply about the implications of our policy for all people, regardless of where they are, regardless of their gender, sexual orientation, religion, ethnicity, country of origin, and whether they are citizens of a particular country or not. AMR is hopefully that prism, that lens that allows us to really develop broad-based and holistic care that extends well beyond AMR. So with that, I wanted to thank everyone for coming and joining, and really appreciate the time that our panelists today gave. So thank you very much.